get us just politely telling us. I don't think we're making a toast for it.
Hey.
We could toast them.
How
When you're ready, guys. All right, so we're calling meeting to order. Happy New Year, everybody.
There's a real.
Winter has finally come. Approval of the minutes. Any additions, deletions, corrections to the last go around, which was November. All right. Hearing none at this time, we can approve those. New business. What is the first one, Phil?
We were asked to comment about a representative from this region on the CMAC, and of course we renominated Dr. Leinhardt, so he is officially renominated as a member from AAREMS, REMAC, for the CMAC. Just wanted everybody to know that, and thank you very much, Gus, for your service.
Well, thank you. I didn't even have time to roll out my super PAC. It'll be interesting. You know, Dr. Doino is the chair of the CMAC now. He's from Remo, so he also works in AAREMS region as well. So we'll have good representation of the CMAC. Hancock, I don't have any these requests and forms in front of us, Phil, so you're going to have to
Hancock has asked us for approval of to begin BLS CPAP. We have the application right here. It's quite thorough and in order, signed off on by their medical director.
Do we know their medical director?
I'm sorry?
Do we know who is their medical director?
Dr. Berg.
Oh, that's right.
That's right. He was here the last REMAC meeting.
Okay. Any objection to CPAP going out, BLS, Hancock? Hearing none, we'll approve that. Central Bridge to use Narcan.
We have signed off on by Central Bridge and by Dr. Luz, their medical director.
All right, and same breath, Sydney Center.
Sydney, the same way Dr. Cruz, their medical director, has signed off on it.
Okay. Can't be much objection to that now that you can buy it, you know, at CVS with a discount from the state. Really nice.
You can actually have it delivered to your dealer.
Who's their new medical director?
Sydney Center.
City
Cruz.
Center.
Dr. Cruz is, he's a medical director in transition, as it turns out, because in just a moment we're going to be talking about that.
Okay. All right. So we'll.
Sydney Center, Dr. Cruz signed their approval to begin use of Narcan, pending the REMAC's approval, and Sydney EMS has requested approval of a new medical director. Dr. Cruz used to be their medical director, and now they are requesting Dr. Guizano. I have the application here. It is properly signed off on, and with a covering note from Jason Gray of Sydney EMS.
Dr. Guizano rings a bell. Is he still working at TRH from time to time?
No, Manny Gazzano, I think he's down in the Binghamton area.
All right, so he's not in their primary receiving area.
No, they're not.
Once upon a time, he used to be, he used to be the medical director for both Sydney Center, and Masonville. Right. Back in the day.
Okay. Anybody want to speak to his candidacy as the medical director? He used to do it. These two squads have reformed themselves, right?
Just Sydney Centers.
Sydney.
Okay. So they have sort of new internal direction and leadership then. Okay. All right. Any objection to Dr. Gazzano as medical director? This we're talking Sydney EMS, different from Sydney Center, is that right?
Oh yes, they're separate agencies.
All right, so Dr. Gazzano, we can approve him. He does at least he did do some emergency medicine. I think he's an internist who works largely as a hospitalist down in Wilson. All right, Sydney Center also seeking?
They're seeking a new medical director, and they, I believe, are, one second, they're not completed.
So that's just up for discussion.
Hang on a second, I think I misplaced that. Let me see if I can take that out. I honestly don't have it right in front of me now. I thought I did, but I don't, about the city center.
Okay, so meanwhile, we'll move on. Unadilla dropped back as to BLS?
As of 12/27, last December, they dropped back to BLS level, and they have, advised ourselves. I'm sure they advised the Department of Health also. Joe, did they advise you?
Yeah,
They did. Okay.
Yes, they lost, they had one paramedic who was very, very strong and very good, Tyler Gregory, and he resigned. So they had to step back to BLS.
All right. So how is the mutual aid thing going with ALS in Otsego County?
We're first up for all Charlie, Delta, and Echo level calls when they're toned.
That's at the
We're
county.
at the same time.
County dispatch. Good. That was a hard fought. All right. Gallopville and Unadilla, Forks. This is informational.
Yeah, they're now updated. Joe can speak to that if you would care to. The BLS first responder agencies are updating, I guess even as we speak, and Joe sends me copies of the letters that the DOH
About
sends to
15 a
them.
day.
I'm sorry.
It's about 15 a day coming in. So
Oh, there is?
it's
Yeah.
difficult keeping up with it.
And what are they updating exactly?
Basically, they're updating numbers of personnel, types of dealers, modalities, and medical directors, and chief operating. So it's just, it's an
there's-
informational thing. For,
Okay.
funding for the education process.
All right.
For
Do they do that on a periodic basis?
the- We're going to start to. For a while, it wasn't really somewhere to get this basic. Now it's going to be done every 3 years.
Every 3 years, okay. That's across the state.
Yeah. Also.
All right. There's a request to streamline the yearly tech re-credentialing process similar to the REMO process. So
I
Phil, you
sent
want to
this,
walk us through it?
Gus, I sent this around to everybody. I had a nice chat with Dean Romano over at Remo and sat in on an informational webinar. He invited me to sit in on it with regard to the tech re-credentialing process. And I sent on January 11th, I sent around to all the REMAC physicians, our REMAC physicians, a draft copy of a streamlining of our re-credentialing process. Right now, we've been using those little cardboard folders every 6 months. It has become a bit cumbersome for the practitioner, also for handling them in the office, and our rate of compliance is extremely high, extremely high. So for the past year, the larger agencies have been putting all the names down on a yearly basis just to make things a little simpler. We've had sort of an informal agreement with them. The larger agencies, CMT, Fulton County Ambulance, Amsterdam Fire Department, and GAVAC, have been sending me just a letter signed by their captain and their agency medical director saying these individuals have complied with all of the tech re-credentialing requirements. Now, Remo essentially does the same thing. They are highly computerized over there, but they've got a lot more records to deal with than we do. So, having chatted with Dean and sat in on the webinar, I put together this little draft that I sent around to all our REMAC doctors on the 11th of January. Dr. Funk responded and had a question or two, and then said that he thought that the outline was a good one. So I'm presenting it to our REMAC physicians for their approval. It would involve each agency, each ALS agency, sending a letter to us once a year, at the end of the year obviously, saying these individuals, the following individuals, have complied with all the re-credentialing requirements as set forth, and these are essentially the same ones that we have in the little folders right now. We have all the records. The agency would keep all the records, subject to an audit. This is what Remo does. And we would be able to very, very quickly, using our computer program in place right now, check off who's compliant, who isn't compliant, and so forth. Like I say, the compliance rate is extremely high. It is well over 99%. It's extremely high. So, and this has held true for the last several years. Wasn't true at the beginning, is now. And in any event, this is what I would request our REMAC docs consider for approval, in which case I would send it around to all the agencies.
Okay, so each agency would return to the region an attestation
Right.
that the following individuals have completed this or
Right.
this minimum.
The minimum requirements. These are the minimum requirements, of course. Yeah.
Right. And then it can be subject to
I think
audit.
Dr. Funk had a comment.
Just after further consideration and discussion with some of the providers that I'm working with, the PALS requirement, in some areas they've substituted that with PALS or PEP. Can anybody, PALS or PEP, can anybody speak to the equivalency or whether that's an
Or
appropriate?
even EPC.
I was gonna say, we're
EPC is approved by
EPC.
the state, so any of the pediatric courses.
Should probably specify, because you can pick up any pediatric course, but something that
No,
covers
that's the-
pediatric resuscitation essentially.
PALS and EPC are both AAHA courses, I believe, correct?
What's that?
No.
No?
Go ahead. EPC is not an AHA.
What
It
who
is not,
puts
it's an NA.
NAEMT.
EMT? What's PEP?
American Academy of Pediatrics.
The one you're thinking of, Beth, is pairs.
Pairs, that's
PALS
it.
and pairs are both AHA courses.
I knew there were two.
Those are the three, I believe, that are approved by the state to count for the core content,
Then we should count.
as long as it's a full course.
It's and specifically, it's not an online course, is what Remo put in. And there's a clause.
So this would insert or expand on the mention of PALS under,
That also goes for the ACLS course, that it can't be an online-only course.
I would agree with that.
so a live course, completion of a live course.
Which is not online.
So it'd be this third paragraph down for paramedic level techs to be in there.
So completion of an ACLS course not online.
Well, I think they're called live courses.
Live courses? Okay.
Aren't there combination courses where you do a test online and then go somewhere for a mega code or something?
It's a course online.
Yes.
Okay, how should we word that?
That's not accepted in the state for, at least the recertification. It's not.
Yeah, our criteria have to be consistent with, obviously, what's
Like
appropriate.
an
at the state
in-person
level.
or live course, I believe is the terminology.
In person?
In-person or live.
Because debt is
Well,
bad.
okay. Now, okay, and in addition to PALS, we have PEP and what else?
EPC.
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 EPC? EPC? Okay. And those courses, is there an online option for those courses at all, or should we specify this a little bit more tightly for PALS and PEP and EPC?
We're just going to say live in-person courses for all of them, right? And just, that could just be a sentence that we tag on to this, all these courses should be live in person versus,
Another thing to consider, some regions use physician contact time for some of the CME hours. Probably not a significant number of them, but I think there's certainly value to physician contact time, as in like emergency department observation. So
How would you like me to word that, physician contact time, did you say?
Yeah.
Okay.
How is it worded in the other regions that use it? Remo uses physician contact time, right? No? Sounds familiar. Okay.
And that says you have to do 24 hours of medical control time, so you actually have to attend a course or you have to shadow
24 hours?
24 hours. A year? And it's really hard.
Yeah.
It's hard to
No,
get that kind of time.
I'm imagining having a couple of hours shadowing in an emergency department with one-on-one let's go assess this patient and that sort of thing. And the physician would have to sign off that there was meaningful time. And I wouldn't like to see it take more than perhaps 2 hours of the required CME, but I feel like that's valuable time and it should count for something.
Where are they gonna go do the time though? Like us, we don't have any physicians, we only have PAs. And to get into Cooperstown even for classes is really difficult.
Gus, are we able to bring paramedics in a one-on-one?
Yeah, I think so.
You don't have to have a physician. Bassett has the physicians. Come join us. How about that?
Right, I'm just saying that, majority
I mean, it's
of the
not a
people-
requirement, but it's something that can
Okay,
be
no, I was
done.
just wondering, because like the 24 hours is a requirement. In order to
Okay.
keep my husband on MAC, I have to have 24 hours of contact.
I don't see 24 hours of time being feasible here,
Right,
for sure.
it's totally different, and that's
Yeah.
all paid, and this is
Right.
volunteer.
I think for someone who wants to use that option, allowing it to count for some of the CME, 2 hours of one-on-one time in an emergency department with a physician, I think would be useful. And then, I guess we could discuss how to document that. But the provider can write what they did, what patients they assessed, what things they learned and talked about. But having it count for part of the CME, perhaps not more than 2 hours. But for some of the CME makes sense to me.
To add to that, and Deb, you already got in Howard forms already developed for this, correct? For clinical time for paramedic.
You're asking me to put on a different hat than I'm wearing today, but yes, I could ask Hudson Valley for copies of their forms.
Maybe
Yeah.
we standardize that form for the documentation purposes.
Yeah, the attestations form too, we have to standardize that.
Yeah, okay.
You can spend as much time as you want.
All right, so in general, is there any objection to the idea of doing the annual, it's an annual thing, Phil?
This will be annual, and
Attestation.
it's going to be a lot more user-friendly, and a lot easier for me to handle at the office, too, as far as checking off the folks and all,
Okay.
Phil, do you want
Paper to
to,
shuffle.
do you want to change your reporting period so that it isn't smack dab at the end of the year or smack dab in the summer? Do you want to go March to March? So
Well,
that
I
you
think
have some downtime, it's a better month to accumulate all of this or something like that?
No, I think Remo does it on the calendar year, and I think we can too, without any problem. Yeah. I think that makes it a little bit easier for the practitioners too, if you do it by the calendar year, and for the agencies.
Yeah, Phil, one thing to consider is, and say there's a paramedic, say Deb is a paramedic. She rides for, huh? We used to do police stakeouts. So anyway, say she rides for Dave and Gus. What happens if Gus keeps her online with his agency, and Dave says, no, she's not online with me? What are you going to do in those situations?
We're online with the region, right?
Well, the Remo changed it with this form. They changed it so there's no more Remo Rangers, to go back to an old term. You're online because you're a medical director, and their liability is only with the agency that you're online with. They changed that about 5-6 years ago.
You have a primary agency, and so that agency takes responsibility to make sure that you have all of these requirements. But when you're practicing with a different agency, you still fall under that medical director's responsibility. But
Correct,
the
but you also have to
documentation-
be, so say you're riding in 3 different agencies.
Right.
Your name needs to appear on 3 different lists. Because they changed it, they said that the medical director's liability shouldn't extend to a different agency. How can that doctor have control or be responsible for you?
So Mary, even though you're listed on 3,
Mhm.
isn't it the primary that's still responsible for submitting that paperwork to say you're credentialed in the region?
Your primary agency.
And so
Yeah,
you would
right.
then have
I
to
put that
provide
in the
that
opening
information
paragraph.
to your other
whomever, right.
agencies.
You have to,
prove
correct.
them.
On the Remo computer system, the primary agency, where according to here, you do the most of your time as you introduced it, would list that you are credentialed with that agency and that medical director is taking responsibility for you in that agency. If you then wrote in other places, you would appear further down on their computer list as secondary, and the medical director would acknowledge that you, Deb, ride with our agency as a secondary provider, but that someone else has to be taking care of your records.
So that's clear in the way.
I think to answer the question that came up from Mary is if you, Dr. Lionheart, wanted her to be online with your agency as the primary, it would state that. But if Dr. Fisher did not want her online, then when she shows up in the secondary agency with him, it would say, no, not with, XYZ agency.
So that distinction, primary, secondary, is spelled out in the remote software?
It is. It shows up, I don't have a copy of it with me, but there's actually what appears to be two separate pages. And now, I'm not a computer expert, I always call my kids for these things. But there's a cutoff with primary providers for the agency, and then further down with secondary providers with the agency, so that you can always look and understand that these are the people that this agency has responsibility for holding the paperwork. These are also people with our agency, but we're not holding the paperwork.
Right. So this all speaks to what this form is going to look like when the primary agency is attesting to their individuals. They're attesting to some primary people. They probably should, on the same form, say the following medics work in secondary providers with our agency, and their primary agency is, and so that's a sort of a connect, for everybody to see that,
We'll put together a little attestation form.
so it's not just a name that's unattached.
I'll put together a attestation form, I'll bounce it off the docs, how's that?
So it's a one-to-one correspondence, so an EMT to agency, there's one primary per, right? You're not going to be primary on several, you're going to be primary on one.
Correct. And when everything's done correctly, you should be primary in one agency and secondary in however many more.
As many as you want. Okay, you
So-
got that, Phil?
If, with their primary agency, they haven't met their requirement for credentialing, and their medical director hasn't signed them off, then they're no longer credentialed to work in the other agencies also?
Yeah, I think if you're not connected to a primary,
Because you haven't met the regional requirements.
Right.
So you can't be online in the region without meeting the regional requirements.
Right. But what if you go from one region to another?
Well, if they go from one region to another, they have to have a letter of reference from the region they're leaving.
the
The
collaborative
question I
protocol
would
is
ask is if your
expanding,
primary
so-
agency's in a different region. So we combat that by, we require all of our staff to run through their skills or provide the documentation to us, whether they're full-time or part-time. We at least know that they've met our regional requirements. They may be online in AAREMS, but their primary, my part-timers may be primary, their primary agency may be Wilton, different medical region.
At the state level, does the state use the same kind of?
For the CME program there, and you're listed for, even for when you use research, primary and secondary agency.
So it doesn't matter what region you're in, really. It's like you have one primary, it could be in a different region. Secondaries could be in another region.
The point I was making with my question, just to make it along those lines, was Remo went away from the global, you're online for the whole region.
Right. They tagged it back to the primary agency. Right?
They tagged it back to, you're online with a medical director. This medical director is responsible for your actions.
Okay.
Or multiple medical directors, as the case may be.
Right, but some are primary and some are secondary.
Mhm.
Okay.
Why doesn't it go to an agency's responsibility?
It is. I think we're
I mean,
asking.
I don't, Dr. I is our medical director. We make sure that every one of our staff meets the requirements for his protection.
I think Article 30 speaks to a paramedic being a paramedic under an ALS system, not under an agency, right?
Correct.
So it's regulatory that says that you're online in a region under an ALS system.
And then how we do it is how we do it. This is how we're doing it. Okay, so the county critical care team, that's an agency, right? Like in Schoharie?
That is an agency, yes.
Yeah, okay. So that's their primary. All right, well, it seems more clear.
You say so.
It's just how it's documented, that's all.
Do we have your approval of this now pending the development of an attesting document that I'm going to send out to the doc?
That sounds like a good way to start it, if I look at the attestation, and I would fill for, as much as necessary to get the distinction between primary and secondary
Okay.
members of the agency. All right, any objections to going with that system? Annual attestation. Who within the agency can attest? Is that an issue? Does that need to be clarified?
That would be the chief executive officer of the agency, the captain or the manager or whatever the title is. Every agency has
And the medical
one.
director.
So it's both.
One and only one.
That's a good addition, Deb. So it's medical director plus?
Yes.
As I mentioned here, the letter would be signed, the document would be signed by the medical director plus the CEO of the agency, whoever that may be.
All right, that sounds good.
Because I just happened to get my thoughts together and I remembered about Sydney Center. Sydney Center, I'm sorry.
Go ahead.
Whether they're a paramedic or not, the CEO of the agency.
Sure. Whoever is in charge of the agency. Yeah.
CEO or COO?
Whoever's in charge of the agency.
Because-
Every agency has to have somebody in charge.
Right. Well, CEO is like your president versus your COO is your chief or your captain. And in our agency, our president doesn't do anything with medical except drive.
Okay. The way I put it down here was the letter shall be signed by the agency head and the agency medical director. The agency head is determined by the agency.
Okay, that'll work.
Can't have a two-headed agency, hopefully.
That's
That's
a
the
multi-headed.
Sydney Center thing. Sydney Center has not selected a new medical director yet. They sent me an email asking, just to let it be known that they are looking for a new agency medical director, and any help that they can be given along those lines, they would greatly appreciate. That's what that was about.
Okay, so that's just informational.
Strictly
Dr. Cruz.
informational, and not appropriate for me to volunteer any position here.
So are they operating without a medical director right now that Dr. Cruz has left?
No, he's nominally still their medical director, but they're looking for somebody else, since apparently he has left the area. Apparently he has not, I don't believe he has resigned as such, but he has left the area, so it is not without precedent that we've had agencies in the area with a medical director whose primary employment was outside the region, but nevertheless, they're looking for somebody else. They just wanted us all to be aware of that. And if any physician would like to help them out, they won't say no.
Okay, offers out there. Margaretville has a question.
Margaretville, yes. Pat Delamita couldn't be here today. She's at a hazmat drill of some kind. She said, I'm reading the email that she sent me. She asked to be brought up. I was talking with our pharmacist about the norepinephrine drip. We can get it in a 4 mg vial and mix it when needed, or he can get it in a premix, but the concentration is different. 4 milligrams in 500 milliliters D5W equals 8 micrograms per milliliter. So this is a twofold question, I'm quoting from her now. Can we carry the premix at a different concentration? If so, is it okay that it's in D5W and not normal saline? He would like to stock it one way for both EMS and the ED if possible. This is the Margaretville Hospital ambulance. And as always, thanks for your help, Pat. This is, she couldn't be here in person. She asked me to bring this up.
I haven't mixed any norepi drips myself lately, but
You're not allowed to.
yeah, that's right. So what comes out of the pitches, I don't really know. It's like a
Does the region have a defined,
formulary.
right, what's in our formulary? Because it should be the same everywhere.
Yeah, let
And
me look it up.
if one particular formulation is easier to get or less expensive or easier to carry or whatever, that's what we
Administration
should all
route is
use.
drip concentration per milliliter or tablet is 4 milligrams. Total per unit, 4 milligrams, minimum number 1.
So it doesn't define the concentration, it just says
Yes, it
4
does.
milligrams?
There it is.
4 milligrams per
Okay.
milliliter or tablet.
Okay.
But the drip
And I-
chart says 4 milligrams in 1,000 milliliters normal saline.
I think the point of that is that they want it to be dilute, so that, if I remember the discussion with the collaborative protocols, is they didn't, you know, if it ran away, they didn't want it to be ridiculously high dose. Doesn't matter if you're running,
We're using
but-
the peripheral veins.
Yeah,
I think
yeah.
the key. And we need
What about the
consistency.
D5 versus saline?
I mean, if it comes in a premix in D5, it's obviously okay, right? So they're asking if they can use 4 mgs in 1,000 premix? That's probably not a premix.
They're saying,
4 and 5.
they're saying, can we carry the premix at a different concentration? We can get it in 4 milligrams vial and mix it when needed, or the pharmacist can get a premix, but the concentration would be 4 in 500 of D5W.
And which would they prefer to use?
She does not say.
Oh.
He'd like to, I think she's leaving it up to the REMAC to make a decision on which way to go, because he'd like to stock it in one way for both the hospital and the squad.
So the protocol says 4 milligrams in 1,000, so that takes out the 4 milligrams in 500 option.
Mm-hmm.
So it means they just need to get a 4 milligram vial and then dump it in their liter of normal saline, which they already have.
Okay.
And that's what everybody should be doing, right?
So
As you
what
start
should I tell her?
introducing changes, then, you know, if one agency carries it one way, another agency carries it another way, someone's gonna make a mistake.
Mhm.
I think what we're saying is stick with the formulary.
Gotcha.
So 4 milligram vial, make it yourself.
I think, you know, that
Cheaper.
we've bumped into this issue in the past when, you know, agents go out of available concentrations or out entirely. I forget how we resolve that, rather than kind of revisit it every time something changes. Did we create some global statement that, like, you know, use available?
There was it was last year that you guys put in a general so that it didn't have to be introduced every time that there was possibly a shortage or, you know, it wasn't available for whatever reason. It was a general statement.
It was a general statement, I'd have to look
And
it up.
I know it's in one of the notes.
There was a list of medications that were allowed to be used
Yeah,
as
we did make
substitutes,
a
and I think
chart.
it was your agency medical director.
Yeah,
Yeah, there was the shortage chart, yeah.
Yeah. But epi has been short.
Well, there's a state policy statement that addresses drug shortages.
And it lists out the different
It lists out what
options,
therapeutic
alternatives.
substitutions are, and the fact that the agency has to go back to the REMAC and notify them.
That they're doing so.
Correct.
Okay, this doesn't really fall into that, right? So they
But
have
any
two
substitution
options.
to the approved formulary needs the approval of the REMAC.
Right, but they're not saying that the approval, the formulary approved version is unavailable or can't be
Right.
created. So if available, use formulary direction.
Mhm.
All right. She's not here, we'll assume that that'll fly.
I'll send her an email.
Okay.
Now, this next one is the most interesting. Ambulance Service of Fulton County reported to me on, at the end of December about a conversation that Frank Sheeran had with the pharmacist at Nathan Latour. Frank is right here, so I'm gonna let him carry the ball because he's the first person.
Well, the concern was we get our morphine supply from Nathan Latour Pharmacy, the 10-to-1 concentration. At the end of December, we went down to restock our morphine, and the pharmacist told us that the 10-to-1 morphine is no longer available for IM. They changed something in the formula. It's only for IV use only. Our concern is they supply the nursing homes ourselves and other places who use a lot of IM. The issue is they do supply it IV, but it's in 2 milligram and 4 milligram doses, which if we go by the straight protocol, to give 5 milligrams, we're opening 2 or 3 vials just to give them one dose. And that's going to put what we carry up a whole bunch. We're just kind of interested in why it can't be used for IV use, or is there any way around that through them?
I sent this, as Frank knows, I sent this email out to our docs on December 30th, and once again on January the 7th, and said we were going to be talking about this, and I sent Dr. Daly a copy of this also on January the 7th, asking him if he'd ever come upon this before. Deb Funk responded she'd never heard of it before.
So, excuse me, your problem is the hospital in Nathan Latour is only getting IM only?
No,
IV only.
Okay,
Yeah, I'm
you
sorry.
said.
IV.
Okay, because we just ran into the same problem with St. Mary's this week. Hospira, our pre-filled syringes of morphine is coming in, it is labeled right on the syringe for IV use only.
So, and which is shocking because we get drugs from St. Mary's Hospital, and ours says for IM and IV use. So, the only thing that we could find, or I could find, I did speak to Al Major from St. Mary's. He said that he has not heard of it being for IV use only. The only thing that we could dig up is that by giving it IM, it's very difficult to predict the peak time for the medication, and you may have pain at the injection site. It was recommended that if you can go IV, but that comes from the FDA. But there was nothing that did. Ours, like I said, clearly states, and I don't know how theirs is different, but ours clearly states for IM and IV use.
Right, so does ours, and we have an
Most of it
earlier,
is.
yeah, we have an older shipment, if you will, from the hospital. Dr. Daly said, quote, "I have never heard of morphine that cannot be given IM, but it would not make sense for a hospital pharmacy to carry it anyway, as the medication may be needed for administration that way in the ED or another setting in the facility."
What's different about it? Is there any real difference between those two?
What's the chemical makeup of it that's made it so?
Chemical makeup's the same.
Yeah.
Supposedly, what the pharmacist or someone in the pharmacy told one of our lieutenants this week was that they either added an additive or took away an additive that the Hospira, the manufacturer of that morphine, did not want used for IM use.
Which is ironic because the morphine we got was westward. So
And
it's
yours
two
said for
different-
IV use only?
It says IV use only.
I think we have to speak to a pharmacist.
I know, we should have invited the pharmacist here
Which one?
from Latour.
All
All of them, or St. Mary's, yeah. I'd be awfully curious.
I would say
Find out
just
what-
use what it's recommended. I mean, that's the safest bet. You're
Right,
The
but now
manufacturer
they're
puts a
being stopped
recommendation
with
on it for a
something that they
reason.
can't use
Well-
according to the protocol. Because we are supposed to be able to give IM morphine, and what you're getting is not usable.
Did you
I see a risk of loss. The more vials that are in that narcotics box and you open it, and we have a diversion here, because
They only supply IV.
we've overloaded these boxes.
Yeah.
Four more vials.
What are they doing in the hospital to give IM morphine?
starting to run into this. Like I said, ours clearly state.
If they can get it. I give this, I am in sub-Q all the time.
Yeah.
I must have sub-Q because it won't hurt. But I'm not aware that it can give it. Never looked.
I called the St. Mary's Pharmacy today, and they didn't know anything about it. You know, they said, "Do you have morphine that can only be given through an IV?" They said, "No." I said, "Can I get any? Are you able to order some?" And we never heard of it before.
Could be a one-off manufacturer that's worried about some kind of liability.
I would ask the pharmacy to give you a formulation of the morphine that you can use IV or IM, since that's what your protocol allows.
They're dedicated to only ordering from one supplier?
Well, it doesn't matter. The hospital needs to supply it to give it in 2 ways, so I can talk to them, so that can be straightened down. Tom, you probably do the same.
As far as I know, there's no.
We don't have it.
Oh, I thought you said you were getting it just IV.
I have a vial yesterday I looked at that was morphine.
From St. Mary's.
From St. Mary's.
So.
Yeah, but you're not getting that anymore. The vials are out.
The pre-filled syringe. I'm getting a picture sent right now of it. I must say
And anytime I'll give it the extent to me, and I'll take it to the best. Trying to figure out where this is coming from.
From time to time in the past, we thought, boy, it'd be good to have like either a pharmacist on this council or a way we could relate to the region's pharmacist through one, spokesperson.
Right.
Like if they had their
has
own.
a pharmacist
That
that sits on
has never really worked out. We've invited pharmacists to be here, and
They got other things to do.
They've definitely declined, either declined, outright or just never showed up.
So I guess we'll just deal with it à la carte and just be one hospital answering one question.
Well, Dr. Daly said, our situation, you can put it in somebody's vein, but you can't.
While you're at it, ask them about sub-Q. It's another thing.
That's why nobody said anything about that.
I am, just not saying.
All right, any other
Any other
business?
new business? Dr. Markowitz contacted me yesterday by email. He had just a dandy of a question about a certain level of practitioner, and I'm going to let him talk about it, if he would.
If we have AEMTs, our new level that replace the intermediates, and AEMTs are considered ALS. So if AEMTs are considered ALS, can they stand down critical cares and paramedics going as an ALS provider in a Charlie Delta Echo call? Are they equivalent as ALS providers per our dispatch protocol? I did send it to State Education asking a similar type question, and they kind of turfed it back towards our direction as what do we do with this? I guess I need some clarification on what is an AEMT and are they considered ALS? And what do we do with it in response?
Dave and I talked about this, and then I spoke with Tom about this at some length yesterday, and we both came up upon an interesting item that we never thought of before, really. An agency, if it had AEMTs as their highest level of practitioner, could not sign on with the state as an ALS agency because AEMTs can't give controlled substances, and you need a controlled substance license if you're an ALS agency. So, in other words, what kind of practitioner is an AEMT? Are they ALS or are they something else?
Well, what about the echo call that comes out, man down, you get there, and it's a drunk? We've all had them. Basic EMTs cancel ALS for that. It's an intoxicated person who was sleeping it off. No reason to do a full roll on something like that. So
when you're looking at an AMT rolling, do they stand down a higher level of care? They're limited in their practice, very limited in their practice. Do we say, or dispatch, you can stop all of their tones, all of their assistants, or any paramedics coming? We've got ALS rolling.
I hear what you're saying.
I think it needs to go a step further to communication. I mean, I brought this up before, but in Fulton County, like, we get a call in Northampton, Fulton County ambulance is simultaneously toned out with us. It's up to like Jack or I to cancel Fulton County if we don't, we're the ALS providers if we're going to handle the call.
What's your level of care?
So,
your paramedics?
Critical care techs.
Okay, critical care techs. So now you're an AEMT.
I would not stop Fulton County till I got on scene, and I've done this as a CCT. I have not stopped that.
But you're
They're simultaneously toned out, but I might need an extra set of hands.
Sure.
But even if I was an AMT, I would not. I think it would have to go back to communication. You don't stop them till you get on scene and you assess. And if that patient's going to require care that's above your level of practice, then don't cancel them. Keep them coming.
Okay. Dispatch queries you. You're an AEMT and queries you. What's your level of care? You are ALS. They stop tones.
Technically, but yeah, I don't have protocols.
So I don't know how other counties are doing dispatch. When Fulton County dispatches a call in Northampton, they dispatch Northampton and Fulton County. So I go from home to the building, or Frank is a paramedic up in Northampton, but I go to the building and go on the call. If my level of care, if I think I don't need Fulton County to keep coming, I just get on the radio and tell them ALS is en route. You can cancel Fulton County. If it sounds like it's a code and we're going to need a second set of hands, I don't care if I was a paramedic or an EMT. I wouldn't acknowledge that I'm en route, but I don't acknowledge to the dispatch that I'm canceling anybody. So Fulton County automatically continues until they're canceled.
So the question is, should a dispatcher keep toning until you have a critical care tech or a paramedic en route to that call?
I feel like they should.
Higher level call. I would agree.
I agree. We need to, and I'm agreeing that we need appropriate level of care responding, But the AEMT is ALS. They query them as ALS en route. You say yes, dispatch is done.
No.
We need to
I don't think
clarify
dispatch
that,
should
that
be
says
given
we
that
need to keep rolling it,
authority
what our
to
level
decide.
We dropped
of
that,
response.
we dropped that entire protocol when we went to the collaborative protocols. It used to be in our previous protocols. We currently have no protocol that clarifies any of that.
How many agencies is this relevant for? Do we have, do we
Everybody
have a
involved.
lot, do we have a lot of agencies that are at the AEMT only level?
No, but even if you have multiple providers, and one's an AEMT and the paramedic's on vacation, it's still an ALS agency, and you're still rolling with an AEMT or ALS. So
Yeah,
it's
we're
not
an
specific.
ALS agency that might only have an EMT.
There are only 7 AEMTs, I believe, in this region at
Right,
this time.
at the present time.
At
there's
the present
seven.
time.
There's no agency with AEMT.
But it
I
becomes the
think that
same
number's
issue,
gonna
can
grow.
a basic,
It's gonna grow.
can a
Volunteer
basic
providers,
cancel
for sure.
an incoming ALS unit when it's been dispatched for Charlie, Delta, or Echo?
Certainly not until you're on the scene.
So, but we have currently dropped that policy when we went to the collaborative protocol.
Well, I think that needs to be revisited.
I think you just
I-
don't
that's what I'm
count
getting at.
AEMT.
We need to revisit
Yes,
this.
you don't count an AEMT. I mean, AEMT is certainly beyond EMT, but for these purposes, they should not be counted as ALS for dispatching
When
purposes.
when the dispatcher asks the AEMT who's now in the ambulance and en route to the scene, are you ALS? I would assume that the AEMT would say, keep ALS coming until they got
They're
there.
asking you, are you ALS? And your answer is, your
I
level
need you to
is
keep ALS coming. I wouldn't even acknowledge that I was whatever I was. I would just tell them that I'm not at the advanced level. I need you to keep ALS coming until I get on scene.
I think we need to put that in writing, because I believe you're gonna end up with providers, AEMTs that
I
believe
think
that
that
they're
that's a
ALS
county
providers.
level decision.
I
The state
do.
defines AEMT as ALS, correct, Mary?
Advanced medical.
She's busy right now.
So I think that it would be up to a county dispatch protocol on what they want to do. Every county can vary. As a basic EMT, I don't necessarily, I mean, even if you get a call man down and you find out he's a drunk, great. You think he's a drunk as a basic EMT. I don't necessarily think that an EMT should be making that decision for several reasons. We can anticipate that, but we've all, or most of us have been on most calls where, yeah, he's a drunk, but you know what? His blood sugar's in the toilet, or
He's a head
there's
injury.
another problem.
Or is a head injury or
And
seizure?
Altered mental state.
I think that that's a county level thing. If the state, classifies it as ALS, how they choose to do narcotics, that's going to be up to them. But I think that it's got to go to a county level dispatch center who's taking that liability to make that determination.
So we just
In our
have to
department,
clarify
it
to
dumps
dump
it onto
counties.
the
It's not
agency,
ALS.
which is fine.
So one
So
of the things
we-
I was going to suggest is you need to look back to what is Dr. Clausen's intent through the priority dispatch cards when he says ALS. Is that IV therapy? Is that resuscitative medications? Is it advanced airway? And it may not be clearly defined, but I would go back because the 911 centers are not governed by the MAC. They're not governed by the region. They are standalone with their own liability. But see what their cards define. So when it says a Charlie response, what is it that they mean? What is the intent to the system as to who is going?
Priority dispatching, that's interesting.
And then APCO is another form of that, but it directly, every 911 center is also required to have a medical director that may very well be able to help this group with deciding in this county or in this region, what is it we mean by ALS?
And I guess Fulton County Dispatch doesn't do priority dispatching. They just dispatch the call. They leave it up to the agencies, I guess you could say, to decide what the priority is for that call.
Maybe something with a suggestion of ACLS qualified?
do we bring out the old protocol and review it?
No, who has that in the archives?
I do.
Phil?
I think a lot of it is in your communications with your dispatch. Now, if I got a pediatric call and I'm a critical care tech, I can't intubate. I'm going to keep a paramedic rolling if they have one on board. I'm going to keep them rolling toward Northampton until I find out exactly what I got. Communications, you got the radio right in your hand.
I think Steve hit the nail on the head. We don't, I mean, if you read Article 30, it does talk about, what the regional council and the REMAC has jurisdiction over, and it does talk about dispatch, I think. But practically speaking, we don't have any control over how counties do their dispatch.
But it should be it should still be a team approach where we're all working together to do it. It's just when it comes to liability.
Software varies, Clausen varies, I mean, whether they use Clausen or not.
Right.
So I think we can advise.
It's communication between these agencies
It would get
within the
pretty
county and the county.
It would get very, I mean, you can see what the next iteration would be. It'd be like, what do you have, what's the call, and then some algorithm that determines whether that patient needs critical care paramedic rather than ALS. Seizures is a good example. Controlled substances, etc. So I don't think we can answer it. Thanks for bringing it up, David.
I guess I have one further submission. Tom gave me a note from Remo, and I'm going to ask him to address it.
So, ketamine, the use of ketamine, our protocol currently does not allow it for standing orders in induction. Remo has issued an advisory that changes their MFI protocol to allow the use of ketamine as a standing order for induction purposes only. Maintenance and or any other use or any other protocol would still remain as a medical control option.
Right, so the attachment is those proposed modifications, or are you just highlighting what?
Well, this is exactly what Remo put out.
But I mean, the bottom label is collaborative New York protocols, and we're part of that.
Correct.
Right? So was this revised in our protocols in the last go-round?
It was not, and it isn't revised in Remo's at this point.
Oh.
This is just a REMAC advisory.
Okay.
I would be in favor of putting out the same advisory. Ketamine is an extremely safe drug and a wonderful drug to be used as an induction agent together with something else such as fentanyl.
And would only be standing orders for induction purposes.
So is the actual protocol, is this a proposed revision to the current collaborative protocol?
Right, the REMAC would have to put out an advisory statement allowing this change. I'm sure that it is going to change when the protocols get revised. Right. This is going to change.
Right, so they made it effective current. So it's already been changed within REMA, right?
But the protocol itself hasn't been changed, and this is just a REMO notification, a REMO advisory. Mm-hmm. So we would have to tag on to it if we wanted to see the same change pending formal change to the protocol. It's only going to affect a very small number of agencies.
Yeah, that's a good
We're
thing.
the only agency that does MFI, I believe, in our region.
I think that's true. Right? Mm-hmm. And how about individuals? We're not credentialing individuals to do MFI, as opposed to agencies.
I don't think so, because the agency has to maintain the competency and all of that.
Okay, there's been some discussion in Schoharie with that critical care team, right?
I don't think Lou is at a point where
they're going
he's
there.
doing that yet.
Yeah, okay.
Okay, so this really only affects Cadillac then at this time.
Right. Okay. All right, so.
It says approved.
Maybe used.
It's a change to your protocols. You have to be careful. Is this advisory just a roundabout way to avoid making an actual protocol change that's been approved? You've sat on the CMAC, Deb. I mean.
No, I know. Do you know what the wording was at the CMAC? It says per approval at the CMAC.
I do not know, and I just tried calling Andy. He didn't answer.
Okay. Oh, is this that if you can adopt another region's protocol without having to go through the whole CMAC approval process because the protocol has already been approved by CMAC? There was that whole thing that was going to make it easier. So
And I
that,
think
right, you
Monroe
didn't have to go
Livingston,
take
Monroe
up time.
Livingston allows the academy.
So they took the Monroe Livingston as their own because it was already a CMAC approved protocol, and we would be doing the same.
The big deal is that when ketamine was approved, the BNE and Department of Health specifically said it may not be used on standing order. So this gives us the, it may be used on standing order in specific circumstance.
Is Monroe Livingston in the collaborative protocol?
No. It doesn't matter.
It was any
It's an
protocol
it's any
approved.
protocol by the state.
Any protocol approved by CMAC could be adopted by another region without having to go through the full.
I
just
understand
have to
you
provide
have 8 regions, you
notification.
have 8 regions that are in part of the collaborative protocols. Now you have one that adopted one from somewhere else, so they're no longer collaborative protocols.
But the protocol isn't changed, just the practices. The bottom line is, does this committee think that we should allow MFI credentialed agencies to administer ketamine on standing order as an induction agent? I would vote yes.
Yes.
Yeah, I would too. I think Mary's question is like, so where does it live and how do you activate it, right? So.
Well, that's my question, and like I said, I just tried calling Andy, he's not at his desk.
I mean, it seems like it could have come out as a collaborative protocol revision.
Except we're not at a revision point, right?
But, well, this is happening,
Mhm.
you know, sort of midstream, right, between revision points.
No, it's,
So.
Right, but if
it's
this
true
is
that
the
we could
case, and
adopt it-
here's my question. If it's good enough for Remo to want to make a change for their people, why didn't they send it out through the collaborative email, conglomerate, whatever you want to
Right.
call it?
this is an agency-specific issue also, because ketamine is required to be accepted at the agency level.
Correct, it's not a required formulary
Right.
drug.
But the
And neither is
protocol for its
MFI.
use
MFI is also a...
Right.
Yeah, I think we just need to clarify. I mean, if this is being adopted by the collaborative, like if the regions that participate in the collaborative protocol can all say aye, then we just revise the collaborative protocol without necessarily going back to CMAC if it's the mechanism that's been established. Like at the bottom of this, it says interim update 2015-89. And this is, what's the date on the calendar?
Even if you were to change the protocol,
There's
the
no-
collaborative protocol, that does not change that protocol for this region, or Remo, or whoever the other 7 people are in there. We have to, in turn, write to CMAC and tag on to that protocol. Just because Remo could change their protocol tomorrow, that doesn't mean we follow their protocols because we're in that collaborative group.
We still have to get approval.
apply
Right.
to CMAC in writing to tag on to that protocol.
But it's a proposed, it would start out as a proposed protocol change that you could then apply to apply.
You don't require, I don't think you require approval if it's something that's already been approved. If it's a change of practice, you have to go through an approval process. But if it's already an accepted practice, you provide notification that you've had these, that you've changed your protocols to this level.
The
Is that right?
protocol isn't changing. I guess all we're asking, ketamine is in the protocol, it's in the procedure, is for that just not to have to call medical control.
Well, that does change the protocol then.
There's no date on Dr. Daly's memo. Do you know when you received it?
But the collaborative protocols affect every agency.
Right.
This protocol comes into effect agency specific. So it's not really, is it really part of the collaborative protocol?
This is a protocol.
You know, when it's the MFI.
Yeah, because if any agency wanted to do it, once they were MFI credentialed,
You
then
follow this protocol.
it's a protocol.
I just think we need to,
I guess it doesn't even say it's a medical control option at this point.
You're right, it doesn't.
Honestly. It doesn't even say it's a medical control option.
But it also doesn't say you need medical control to give the continuing ketamine dose later.
Right.
Doesn't say a standing order.
It doesn't say standing order, it's just,
yeah. So who was this sent to? It says REMAC notification. Was this sent to Remo's REMAC or is this being sent to?
Well, it's
This
on
was
Remo
sent to
letterhead.
Remo agencies.
And we just got a copy of it?
Correct.
Wonder how that-
So I think, can somebody ask Dr. Daly?
I have a message out to him right now.
If this is proposed as a, agency, within regions, agency specific, that do MFI revision to that part of the collaborative protocol. Like in the old days, we had a binder, and if we changed a protocol, we would take out the old one, and you'd put in the new one, and have a date on it. This has a date of 2015 on it, so I don't know when this might have occurred. When did this occur?
This piece of paper is exactly the same protocol that is in
The approved protocol?
the approved protocols, word for word.
All right.
I think it's just clarifying when something's a standing
okay.
order versus when something is medical control.
Because the little asterisk, New York State ketamine policy applies, specifies it's not to be used without direct medical control, last I knew. Except that it sounds like the CMAC recently changed that.
So it has not changed the wording of the protocol at all. All it's trying to do is clarify what's standing order and what's medical
All
control.
we did was remove the asterisk?
Well, no, I think New York State ketamine policy applies, but it sounds like New York State ketamine policy has changed.
The ketamine policy has not changed. I think they approved it in this particular protocol if it was changed. The same policy 1014 still exists. It has not been changed.
Then what's he referring to? Per approval at the CMAC and policy of Bureau of EMS. Ketamine can be used without a direct physician order.
We have not issued a new policy statement on ketamine.
All right, well, let's...
Joe, do you have any idea?
We are trying to stay...
He was trying to say.
Just need more information.
Yeah, one of the challenges of the collaborative protocol is that, you know, if one tentacle moves in a certain direction, what happens to the rest of the octopus?
But now,
So,
what was that legal document-looking thing that was sent around that if you were going to sign on to the protocols, that someone would act on your behalf?
Legal document.
That, the one that said there's one representative from each region who will act on behalf of the region at the collaborative protocol groups.
All right, so we'll try to clarify.
Michael Daly says that the intent is for it to be changed in the protocol so that it's standing order for RSI or sedation. What's X? He says that there's a memorandum of understanding, and he's asking if we're going to sign on to it, and he points to Bill Fisher.
Okay, I just found the MOU that he's talking about. Protocols will be created.
The tables are skirted so you can hide.
Okay. All right, well, that's clear.
So you have a memorandum of understanding that we need to sign?
I haven't, because it was sent to me from Mountain Lakes, right through their REMAC. I'll show it to you. Supposedly it was sent out to everyone that's involved in this. No, but, and that's why I was asking, how does that document tie into this? Is my only, you can make it bigger. And,
This is just for the collaborative protocols, not specifically for ketamine.
correct, but there's a thing in there about how they're going to work and that only quarterly will they meet, that it's up to the local REMAC.
So that's a different issue. That's, are we going to sign the MOU?
Well, that's
for
what
collaborative
I think that's
protocols?
what he's
Yeah.
referring to, though.
Well, what about the ketamine? The ketamine is in there as standing order unless, except that the New York State policy says it can't be standing order, right? So unless there's something new.
The policy statement for the state says ketamine may only be administered to a patient under direct online order from medical control physician. Is what the policy is right now.
I think that has been changed in protocol at the CMAC level.
I don't recall that. Sounds like more research needs to be done
Right.
before anything changes.
Can we approve it pending legality being discovered?
Hey, wait. Did they change ketamine so it can be given on standing order?
Why wouldn't we wait until we're more sure of what's going on before we approve?
Oh, Okay, I'm at the AAREMS meeting. The reason I'm asking is Remo put out an advisory requesting that ketamine be available in standing order for MFI.
The MOU.
And Mike said that there's an MOU in place and it's being worked towards, and he asked if AAREMS was going to sign on board with this. So. Okay, so, because he never responds. I know. But Deb Funk is raising the question, or Deb, I can never say her new last name now, but Deb V is asking, you know, can we approve this if ketamine is still only on direct physician option per our policy statement?
Whatever you say for cell phone.
Right.
You move slower, but probably more thoughtfully.
So Bill, you were supposed to address this MOU, he says.
He sent it to me, he says.
He sent it to him because he has to sign it. Don't even ask.
So it's in the works. So the question is, would AAREMS be within their right to approve this if it's not really, or should they wait 2 months till their next REMAC meeting? They can wait? Okay. I'm getting this stink eye.
Yes, ma'am.
All right, thank you. Right?
She said put the brakes on.
We've decided to wait.
It's in the process of being approved. There's some steps that have to be done. Lee has submitted a request to B&E, and it has not been responded to.
They never respond to anything.
You heard me say that.
I was wondering who you were talking about, but.
Yeah, there is, it's in the works, but it hasn't been approved yet. She suggests putting the brakes on for until the next meeting at least.
It sounds like it.
So, I mean, that's purely her comment.
Okay, so when we get some sort of documentation, then we're in a great place to approve it.
That's right, that's what they did. I'm not coming up with that in emails. Have a Merry Christmas card.
So are we officially tabling this then?
Yeah, I think so, just to be within the bounds of medical director, we have physician.
Sounds like we need to also figure out what this MOU is about
Process
and
is,
get
yeah.
this sent around for the next meeting as well.
Yeah. You said, if you have it, Bill, and you actually,
I'll try to
send it
figure
to
out
Phil, and Phil can blast it out to REMAC.
I was gonna say, I have it on my phone if you want.
I got it.
I can forward it.
Is it
Forward to Phil, and Phil to forward to everybody.
Yeah. All right, well, that was clear.
We do not have any information for we don't have any material for an executive session.
Excuse me, just to revisit the thing with the morphine. Currently, we have a mixed bag. We have two different kinds of two different morphines in our stock. One says for IV use only. One says for IM and IV use only. REMAC want to just say follow the manufacturer's recommendation. There was something with a preservative. It could have been made during the morphine shortage that it was not to be used for IM use. And it clearly states so on the syringe.
I recommend using the IV use only for IV and the IM.
Or IV for either or.
I don't think the REMAC has an opinion about that, because it's not something we actually know. I think I would want to find out what the manufacturer, what the prohibition is on using an IM. If the pharmacist says there is no prohibition, there's your answer.
I have a message into our pharmacist.
So who is going to find this out and let us know?
Well, it's only, I think it's emanating from one facility, right?
There's two different facilities. Now it's only one. St. Mary's, their new stock is for IV or IM use.
Okay, it's the first we've heard of it. May it be suppliers, you know, it's very supplier dependent. The hospitals use different suppliers.
Perhaps something can be gotten in writing from Nathan Latour. if they're willing to put it in writing, which I somehow doubt they will be.
I think that the formulary though is clear, and it says that it needs to be for IM use. So if you can't get it because the hospital only has one supplier, then the agency needs to look at a different supplier.
They have to get an exception.
If you have to go-
The hospital needs IM too, I mean, it's done. So that's, I'll talk to the pharmacist and do a separate thing.
I mean, if it's necessary, you can amend your controlled substance plan, and I hate saying this because it's more stuff across my desk. But if necessary, you can amend your supplier agreement in your plan.
To be able to get the drug that you need.
Correct, because it's important that you have what you need in the correct concentration and form so you don't have the drug errors.
You have fentanyl, right?
So,
Well, fentanyl is the only one that is very strict that it cannot be in a pre-filled syringe. Fentanyl can only be ampular vial, but everything else you have leeway.
So FYI, Dr. Daly believes that the Department of Health made comments on the record for CMAC and SEMSCO that says ketamine can be outstanding over.
Lee is looking to see what was recorded on that. She's aware of Mike's goal intent memo.
Dog with a bone. Yep.
Just we have drugs and formularies and all that. Do we have, Phil, what percentage of PCRs in our region are electronic?
What percentage?
Yeah.
I have absolutely no idea. I'll have to dig into that.
I mean, if it's significant enough, like half or more, we should be able to start to answer questions like, how are these drugs actually being used?
Well, when you say percentage, though, is that if you go by percentage of calls being run, it's a significant amount because your bigger volume agencies are on it.
We have,
But if
we have
it's
15 agencies that are electronic now, but that includes all but one of the larger agencies, all but Fulton County. Fulton County is going electronic next month, so we'll have all the larger agencies. So the percentage of PCRs will be quite high.
So I just wonder whether we could do a drug analysis of 2015 and say, what did we use? How was it used? For what? Even the last question we could leave off. Just what are we using? How did we use it? Because, you know, if IM morphine is kind of, you know, an abstract theoretical, we can just get rid of it. You know what I mean? So, and we don't know.
We're using it on IM.
We don't know our own data. We don't know how drugs are being used. It's with frequency.
Gus, if I may add to that, it's also the perfect time to look at things and say what drugs should have been used.
That's hard to look at.
It is. It's very difficult, but you maybe you've got cases coming in of, I don't know, you've got cases coming in of the asthmatic and, you know, medication A wasn't administered because they were only 5 minutes from the ED.
Goes back to
Those kinds of things.
regional QA committees and get them up and out, you know.
Can we look at that?
The point is you wouldn't want to necessarily remove a drug from your formulary based on what was given, when in reality it should have been given much more, and there's an educational opportunity.
Right. But like oxytocin was for a long time, I think, in the formula. Somebody thought it was a good idea, and it, you know, it hits the protocol, and we're always on output. We're always putting out new drug protocols. Do this, do that, do this. We have to, at some point, assess what actually is going on. So, and where does that reside, Phil? Does the EPCRs from our region, do they live in your office?
Well, I can go to the State Bridge and run a report, yeah. I can tell you.
I'd just like to see, like just 2015, for example, AAREMS region, or we could do it with REMO, and just get a list of frequencies of drugs. And then we could run it against the formulary and say, you know what, this is everything.
I can get you that figure on what percentage is electronic now. It's quite high. The percentage is quite high, simply because all of the agencies in our region are
yeah, Mary's got a good point. Like if we just use the number of runs in the region, what percent of them are electronic, we'd have a chunk of data. All right, any other business for REMAC?
Just an FYI, I saw the expression on Tom's face when I said I was wearing a different hat. I have left the program director's position at Hudson Valley, stayed away from this meeting for just a couple of months, and like all EMSs, got tagged to do something else. The something else is augmenting the quality improvement position at REMO, and so I'll be coming to these meetings, either Dean or myself, as a representative from REMO. So, and I was asked today to simply read into the REMAC minutes a note from Tim Mirabile, just a reminder that REMO's moving forward on its improved call recording system. The anticipated start date is mid to late spring on that. There is opportunity for additional hospital hubs, so if that were a concern for added areas, it could be addressed. And you don't want to call me on that. As I said, I ask my kids how to program my phone. So I do have Dean Romano's cards if you have technical questions and would like to speak with Dean about it. I know some information has been provided already to this region, but if you had more questions, Dean would be the person. And I'm glad to be back, even with a different hat.
Nice to have you.
Thank you.
You'll never get away.
You know, that's the thing. My son-in-law says to me, do you not understand the word retirement?
It's actually nice.
One more thing, the Epi Inject program, or the Check and Inject, is in full action right now. Beth did bring one of the training kits, so everybody can take a look at it if they want to see what's actually out there and what everybody's using, and the syringes and the kits.
What's CVS selling?
All right, any other business for REMAC? All right, we're adjourned, thank you.
Adjourned at 11:50.